All right. Good afternoon, everyone. I'm Erik Escuro. I'm one of the rheumatologists over at WVU Rheumatology. I am not born and raised West Virginia, but I did my internal medicine residency here back in 2016 to 2019. I then met my now wife while I was here. She's from Beckley, West Virginia. We left for about 5 years when I did my rheumatology fellowship at Penn State, and then ended up doing 3 years as a rheumatologist in Myrtle Beach, South Carolina, in a solo practice. And ultimately, we got called back home to come back to Morgantown, and we're really happy to be back. So, today we're going to be covering a very common topic and one that is near and dear to my heart, as we'll discuss in a bit. We'll be talking about gout. Nothing to disclose. So, learning objectives today are to discuss the signs, symptoms, and recommended diagnostic workup of gout, to understand the treatment guidelines in reference to gout, and then apply some of this knowledge of the workup and treatment to cases of gout that I have some prepared, but obviously much preferred if you have cases that you'd like to discuss on your end. So gout is not a new condition. There are some diseases in rheumatology that we're just discovering over the last couple of years, like Vexus syndrome back in 2020 or so. But gout has been known for centuries. And this is a piece of art done by James Gilray back in 1799. And this is a very accurate depiction of what it feels like to have a gout flare. I would know. Now, this little beast or demon that they described it back in the day actually has some resemblance to maybe like a cartoon version of a rat, which will be very appropriate as we talk about some of the workup in the future later this session. But as you can see, the typical features of gout: that red, hot, swollen first toe. Over the years, gout has affected many of famous people. King Philip VIII, Queen Anne. If you watch that movie, The Favorite, back in 2018, they depicted her struggle with gout throughout that movie. And it was oftentimes called the disease of kings, mainly because, kings and queens back then had a very rich diet full of red meat and seafood and ports, wine, all the types of alcohol. And so, of course, they were the ones who ended up having this disease of having too much of the rich food. And so when we think of gout, we think of that first toe getting red, hot, and swollen, oftentimes in association with some type of food or ingested alcohol, something along those lines. Now, gout doesn't have to just affect those joints, though. Gout is the most common inflammatory arthritis. So when compared to things like rheumatoid arthritis and psoriatic arthritis, gout is much more common. It affects around 9 million adults in the United States, and it is actually on the rise. So there have been studies that have shown gout in the 1970s and 1980s compared to the last couple of years, and the number of cases has increased significantly. So as I mentioned before, gout flares typically involve that first toe, what we call the first MTP, but it can also affect the midfoot. It can affect the knees, and later on in the course, or in atypical presentations of the disease, it can also affect what we would call the more peripheral joints. So, like in the hands, the elbows, but even rarely it can affect the spine, which is an area that you don't typically think of when you think of a gout flare. The reason why gout occurs is because most people, most humans, have a measurable amount of uric acid in the blood, but then it reaches a tipping point, a point in which your blood can no longer dissolve that uric acid into the blood itself. And then it sort of solidifies or crystallizes into these monosodium urate crystals. And your body doesn't like that being there. And so once it notices that the crystals are there, the body will attack it with the immune system. And that's when your joint gets red hot and swollen. So when it comes to gout, there's different stages in terms of the gout progression. And usually there's a long period of what we would consider to be asymptomatic hyperuricemia. So no symptoms, but if you were to get a uric acid level, you would expect it to be high meaning anywhere above like 6.8. Now, at some point, though, assuming that it's not controlled well enough, these patients will undergo a typical gout flare, again, usually in the foot, especially at that first MTP, or in the knees. Now, sometimes patients are lucky enough to just have one flare, But sometimes it calms down and you reach this time that we call an intercritical period where you still have gout. Don't get me wrong, you still have it, but you're not getting the acute flare. But then you start hitting this cycle where you start getting flare after flare after flare. And that's where we, as medical providers, try to break that cycle to make sure that patients no longer have these types of symptoms. And unfortunately, sometimes it gets so bad that you end up having advanced or severe gout, where you can have visualized nodules, for instance, on the feet or the elbows, or even such a bad arthritis that it ends up mimicking that of rheumatoid arthritis. And so, whenever we talk about gout, we talk about a number that we're trying to a number that we're trying to hit, which is a level of 6. Now, as I mentioned before, 6.8 is the level at which your body has the ability to dissolve the uric acid before it crystallizes. And I think about when I was a kid back in the 90s when it would be a hot summer day and come back in and my mom had some of these Kool-Aid pouches or that container of the powder, and the instructions say for every 8 fluid ounces of water, you can use 1 packet. And I think to myself, 1 packet? I'm going to use 2 packets. Or if it's like 2 scoops, I'm going to use 4 scoops. And you dump it in there, and you're stirring it up, and then it tastes really sweet, as sweet as it can basically get. But then you look at the bottom of the glass and you notice that the powder has precipitated to the bottom, meaning fluid only has the ability to dissolve so much solute into the fluid itself before it will precipitate. And so we call that like a saturation point or a solubility point. And so our body's ability to dissolve away all that uric acid cuts off at 6.8. And so if somebody's sitting at 7 or 8 or 10 for an extended period of time, then you would anticipate that it will crystallize somewhere, and it tends to be to the cold joints, the feet, the hands, the elbows, things like that. So our job is to try to get that uric acid level low. Because what we're ultimately trying to prevent are these types of nodules that can appear in, again, the cold areas. And these are what we would call tophi. These are advanced stages of gout where the level is so high that the body at some point just gives up. It's like, all right, if my body is not going to dissolve away this uric acid, I'm just going to wall it off. And so what it does is it takes those uric acid crystals and it starts to calcify them. And once it calcifies, it turns into this white chalky substance. And these areas can be quite debilitating, and it can start to eat away at the joint. And sometimes it can get so severe that these areas break open and get infected. And these areas can oftentimes be quite painful too and limit your use of those joints. And so as medical providers, we're trying to prevent this from happening because gout is absolutely a manageable disease given today's medical treatments. Now, there are some things that you can change and other things that you can't change when it comes to your risk factors for gout. So there are some modifiable risk factors, like if you eat a ton of ribeye steaks and a lot of seafood, and you're drinking a lot of beer. Those are things that you could probably avoid and help with not having as many gout flares. Sometimes it's something that the medical providers did. So I had a patient once that was being treated by our oncologists for a blood malignancy, and he was actually on tacrolimus after a bone marrow transplant. And the TAC was actually the reason why the gout was flaring. And then there are some things that you just can't change, right? Non-modifiable risk factors, including increasing age and your sex, males having it more than females. Although females can still be affected by gout, and it actually ends up leading to underdiagnosis a lot of times. Now, I'm not going to go into too much depth about the classification criteria of gout, but in rheumatology, we have these things called classification criteria versus diagnostic criteria. So classification criteria are more so to get people into research trials. And the big thing I want to take away from this, though, is step 2, where it says a sufficient criterion to get into a gout trial is if you have monosodium urate crystals in a joint that is currently flared with gout. So you pull the fluid out from that joint, you look at it under a microscope. If you see gout crystals, you're done. This is gout. Whereas in real world medicine, I'd say a lot of the times people are diagnosed without getting a needle into that joint and just sort of a presumptive diagnosis. And that's where we run into a little bit of a dangerous spot, to be quite honest, because who's to say that that red hot swollen joint isn't an infection, and is it truly gout? So in these trials, we really try to hammer in the diagnosis with a synovial fluid aspiration, but we do take into account that sometimes that's not feasible, and sometimes a really high uric acid level, like being above 10, in combination with a tophus, like that chalk-like substance, maybe that's enough to call it gout without getting a sample. Now, the EULAR criteria, which is the European version of the American Society that heads up rheumatology, they put out some recommendations back in 2019, which even again hammered home the importance of trying to find that gout crystal, because much like if we were working up a malignancy, even though it looks like a duck and quacks like a duck, you don't really undergo chemotherapy until you end up getting that biopsy, right? Where you're confident that it is a malignancy. Here as well in gout, although it looks like a duck, it quacks like a duck, you think it's gout, unless you have crystal proven disease, there's always the possibility you're missing something else, whether it's infection or a different type of inflammatory arthritis like rheumatoid arthritis. Now, one thing to keep in mind, though, is that you can still search for those gout crystals even in the absence of a gout flare. So if you have somebody that has a gout flare to their knee, and you personally don't have the ability to draw knee fluid out of that knee based off of a lack of resources, or maybe you just never did it before or got trained to do it, if you were to send that patient to an orthopedic surgeon or a sports medicine doc that you have in your community, even if you're past the period of a gout flare, they could still try to get fluid from that knee and look for the monosodium urate crystals, and that would be sufficient to put a diagnosis of gout as well. So just a throwback to medical school here. The image on the left is your monosodium urate crystal. It's that needle-shaped, strong, negatively birefringent yellow crystal when parallel to the compensator array, whereas pseudo-gout is on the right, or calcium pyrophosphate disease, where it's rhomboid and it's weakly positive. Now, as I mentioned before, in a case in which you hope that you could make the definitive diagnosis with synovial fluid aspiration, that's all well and good if you have the ability to do so, but sometimes you don't have those things available. And with advanced cases of gout, sometimes the X-ray can give you typical findings. So as we see with radiology, sometimes the arrow sign where they tell you what's going on. On the left, you just have the plain film by itself, but on the right, it shows you what's going on. Gout erosions look different than the erosions that you would expect in rheumatoid arthritis. So it has a very specific finding called an overhanging edge with a sclerotic margin. And so the other term for this is a rat bite erosion. So if you think back to that image that I showed you at the beginning of the presentation where it looked a little bit like a rat, that little demon thing, it's funny because we ended up naming the radiographic finding sort of after that, where it's a very well punched out lesion like you can see with the outline on the right. That soft tissue swelling that's present is obviously, in the setting of a gout flare, but even if somebody has a tophus there or that chalky substance, sometimes it shows up as a little calcified structure in that area where you would assume that, that would likely be a gout erosion, or a gout tophus. And then you can also see that narrowing of the joint at the first MTP. All of this could also be present in the setting of osteoarthritis. But you combine all of those things together and the clinical suspicion for gout increases significantly. In areas that have this available, like we have fellows here that are working on their ultrasound skills, sometimes you can actually capture it on ultrasound. And so in a case where you're not having an advanced case of gout, like years and years of it, but instead it's the first flare, instead of putting a needle in there, sometimes you can actually put an ultrasound probe on. And that middle image there is what we call the double contour sign, where you have that enhancement both at the edge of the bone as well as the neighboring structures. And if you get that two-lined appearance of the double contour sign, that can be sufficient for a gout diagnosis as well. In cases where you look at a nodule and you're not sure, I think this patient has gout, and there was a presumptive diagnosis that was made years ago, and there's just this lump on the finger or a toe, and you're like, maybe it's gout. Sometimes we pursue something called a dual energy CT. And this dual energy CT will show areas in green that are areas of suspected tophi. Now, this can be quite helpful as well in those very rare or atypical cases where gout is affecting the spine. So that bottom right image is an image of a gout tophus in the lumbar spine. And that could be enough to prove gout as well without having to dig in there and get a sample. Here are just some more images of what we just discussed, the double contour sign on the top there on ultrasound, some gouty deposition or the tophaceous deposition, like that right image with the green right in the Achilles tendon. So without having to go in there with a needle to suck it out, you would say, okay, that does look like some sort of tophus back there. And then more examples on the bottom there of the rat bite erosions on plain films of a first MTP consistent with gout. So the big thing is, okay, so if we're going to diagnose it, you want to hopefully get some fluid out of there and just prove it. Maybe you had to go over more of the clinical diagnosis and get some x-rays or ultrasound and that proved it. But ultimately you want to know, well, how do I treat it? Right. And so when it comes to therapies, there's always the acute management as well as the chronic management. And the acute management are the three medications you see here. We are not strangers to these meds, right? Colchicine, glucocorticoids or steroids, and then NSAIDs. And really, the selection of which medication to use for a gout flare oftentimes depends on the comorbidities of the patient or the other types of medications that the patient is on. Now, I will say that colchicine is my favored medication to use, not just because it can be quite effective, but also because colchicine ends up being a little bit diagnostic as well. So if you have a person that maybe has some pain and swelling in the foot, with a strong family history of gout as well as rheumatoid or arthritis, and you're not sure which one it is, well, if you give them colchicine, that will help a gout flare, but it's not going to help a rheumatoid arthritis flare. And so sometimes the response to colchicine tells you a lot. So the way that we dose it is by giving two tablets or two 0.6 tablets together as a loading dose, followed 1 hour later by a zero point 0.6 milligram tablet, so 1.8 milligrams in that first day. And then 24 hours later, you can start administering it zero point 0.6 milligrams twice daily until the flare resolves. For glucocorticoids, prednisone, we'll usually dose prednisone as 0.5 milligram per kilogram. So if we say we have a 60-kilogram patient, you could start a starting dose at 30 milligrams of prednisone, use that dose until the gout flare subsides, and then taper over the course of the next 7 to 10 days. And then finally, when it comes to the NSAIDs, we use what we would consider a full anti-inflammatory dose. So like full dose diclofenac, I know it says 50 here, but you could use 75. Naproxen at 500 milligrams twice a day. But keeping in mind, as I mentioned before, comorbids. So if you have a history of stomach ulcers or chronic kidney disease or severe cardiovascular disease, you don't really want to use a lot of NSAIDs, so we would avoid it. For glucocorticoids, if you have a strong, significant history of severe diabetes, you don't want to be driving up the blood sugars by using a lot of steroids. And then in colchicine, for somebody with advanced chronic kidney disease, unfortunately, that can lead to a lot of blood count drops. So you want to be careful with that. Or if you're on a different medication that's like that could using a med that strongly inhibits like cytochrome P450 or P-glycoprotein, like clarithromycin, there's a lot of medication interactions there too. So you sort of have to pick and choose which medication you're going to use here. Again, I think colchicine has that ability to give you a little bit of diagnostic information, whereas steroids and NSAIDs, if somebody has an RA flare or just osteoarthritis, those things will probably help too. Now, you'll notice that in each category, there's also prophylaxis. And so one thing that we often find ourselves forgetting, and myself included, is that you're so concerned about treating the gout flare that you forget that once you start urate lowering therapy with allopurinol, you actually have to keep those patients on a prophylactic dose of one of these meds too, with the idea being that if you start allopurinol, you might induce a gout flare. And so by keeping them on a stable dose of colchicine, prednisone, or NSAIDs for 3 to 6 months daily, of those types of medications, you can successfully get them on allopurinol without inducing gout flares. Now, you probably won't see this so much in your practice, but in the hospital here, in complicated cases where you can't use any of those medications during the middle of a gout flare, we sometimes turn to our RA medication, what we call an interleukin-1 inhibitor, like anakinra, and that can be used to resolve a gout flare as well. And then corticotropin or ACTH can be used, but I don't really use it in my practice. So when it comes to treating gout flares, I think that we're quite good at just, prescribing the medication that's needed and the patient gets better. But when it comes to the preventative medications, like the urate lowering therapies, allopurinol, sometimes patients aren't very adherent. So this was a study done back in 2008, when at the time we had allopurinol and probenecid already. And they found that in this study that out of 7 different common chronic medical conditions, gout actually had one of the lowest adherence rates compared to some of the other things like blood pressure issues, cholesterol issues, and even osteoporosis, which was quite surprising. And so it's always a question about whether it's an education component that's contributing to this side effects. Um, it's something that we just have to be mindful of that oftentimes gout medications fall through the wayside. Now, there are several ways in which we try to attack gout from a preventative standpoint. And sometimes we will try to inhibit the production of urate. Sometimes we'll try to excrete it through the urine. And then in other cases, we'll take an enzyme that humans don't typically have in the body. We'll borrow it from something like a pig and we'll make our own. We'll put it into the patient and we'll just chew up that uric acid if we can't get rid of it in other ways. So the most common medication when it comes to the treatment of gout would be the xanthine oxidase inhibitors, with the most common one being allopurinol. So allopurinol, based off of the American College of Rheumatology 2015 management guidelines, is our first line therapy. Very easy access, cheaper than our other options. And we just have the most experience with it because it's been FDA approved since the 1970s or 1960s. So allopurinol, usual starting dose is about 100 milligrams a day. And I think this might be surprising to some. You can do a gradual adjustment of it up to 8 to 900 milligrams in a day. Now, if you had to poll yourselves, or if you looked into patient charts and you looked at the most common dose of allopurinol that is out there in patients, I think you would agree that you don't oftentimes see people on 800 milligrams of allopurinol. Does anybody, I have a theory behind this. Does anybody want to guess my theory on why you just never see that? My theory is because the only two formulations of allopurinol come in 100 and 300 milligram tablets. And if some drug company made an 800 milligram tablet, I think people would be a lot more comfortable prescribing an 800 milligram tablet. And so that doesn't mean that it doesn't come without its risk, but you do have to monitor it appropriately. But it's actually not failure if you don't hit the level of 6 on the serum uric acid level on just 300 milligrams of allopurinol. That just means you got to go farther. Now, there are things to keep in mind. For instance, there are some very dangerous side effects of allopurinol in certain populations, like allopurinol hypersensitivity syndrome, which is very similar to that of DRESS syndrome or Stevens-Johnson syndrome. So you got to be careful about that. Coexisting medications like azathioprine, we got to be careful with that. But for the most part, allopurinol ends up being a very safe and well-tolerated medication. Now, there are other xanthine oxidase inhibitors like febuxostat. This one's a little bit more limited. It really only comes in 40 and 80 milligram tablets. It also comes with a black box warning that we're going to talk about a little bit later. Probenecid, pretty like expensive for what you get out of it. It's not as good as the xanthine oxidase inhibitors, and it costs like 4 times as much. But when allopurinol is not working, sometimes we'll bust out probenecid instead. And again, there's not much titrating that you do here. You start off at 500 milligrams twice a day and you go up to 2,000 milligrams. Now, there are times where you don't use these uricosuric medications. Sorry, I always have to say that slowly. Basically, if you have a history of chronic kidney disease, well, your kidneys aren't going to urinate out or pee out this uric acid very well. So probably not the best patient population to use it in. If you have a long history of kidney stones, that might exacerbate those issues, as well as having some sort of like blood count issues as well. And then there's our new medication. By new, I mean back in 2010, but this is when you take an enzyme that's not present in Homo sapiens, and you end up giving it to humans, and you just chew up the uric acid. So you might have heard of its cousin rasburicase, which people will use in the oncology world for things like tumor lysis syndrome when the uric acid level goes super high. But here in gout, we have a version of it called pegloticase. And this medication is infused over the course of every 2 weeks for several months in a row. And this stuff can just melt away those chalky tophi that I showed you previously. This medication, though, has a very high anaphylaxis rate. Again, you're basically putting an enzyme that's not usually present in humans, and it's usually present in pigs. And then it's like a synthetic version of it, but your body doesn't know the difference. And it looks at that and it's like, why is a pig in here? And so then the immune system attacks those antibodies, and then you go into anaphylaxis, usually on your second or your third infusion. The New England Journal of Medicine actually published a paper just a couple of years ago that said if you actually use a rheumatoid arthritis methotrexate along with it, it drops that anaphylaxis rate from like 33% all the way down to 1 to 3%. So it's become a lot safer. You'll notice that if we in rheumatology are using pegloticase for a really severe case of gout, that we actually took away the allopurinol because what happens is that one of the markers that somebody's about to have a really bad reaction to pegloticase is if the serum urate level starts to increase past 6 milligrams per deciliter. That just goes to show that the body's creating antibodies against the med and the med is becoming ineffective. And so if you actually have allopurinol on board, it might blunt that uric acid rise. And so then you don't know that you're about to run into anaphylaxis with your next infusion. So we usually take the allopurinol away before we end up using the pegloticase. So on the left is a picture of somebody with really bad tophaceous gout. And just after a couple of treatments of pegloticase, you'll notice that the left second PIP, the right third PIP, and the right third MCP, those really big nodules just melted away based off of using just a couple of treatments of pegloticase. So it's a really incredible med. The issue is that it's super expensive. You know, just one course of pegloticase over the course of several months can cost up to $50,000. So it's definitely not a medication that you use without trying cheaper medications and exhausting your other options. So I'll briefly go over some of these treatment guidelines. We covered a lot of it already with what we've discussed, and I want to make sure we get to cases. But in general, we have these treatment guidelines where there's the things that we do that are supported by evidence. And then there are some of the things that we do just because we do them. And then there are other things that we do that actually are not supported by evidence. And the American College of Rheumatology said you should probably stop doing that. And so when it comes to selecting the patients with gout that need or should be receiving urate lowering therapy with something like allopurinol or febuxostat, it's not every patient with gout. You know, it's actually usually only patients that have 2 or more flares in a year. So if you look at that third PICO question, it says for patients with frequent gout flares, 2 or more in a year, we strongly recommend initiating urate lowering therapy over no urate lowering therapy. Whereas if you go 2 below to it, it says for patients experiencing their first flare, we actually conditionally recommend against initiating urate lowering therapy, mainly because the outcomes actually don't show that you're preventing much else if you have infrequent flares, and you also, avoid the risk of having some of the side effects of some of these medications. Now, other situations in which you should be using urate lowering therapy is if the patient has the advanced gout. So basically, if you have evidence of tophi, that's a sign that you have such a high uric acid burden that your body is just calcifying it now, and there's no, you really need to try to find another way to get that uric acid out of there. Or if you got something like that X-ray that showed that rat bite erosion, again, that is advanced gout. So even if they're having infrequent flares, you really should be starting something like allopurinol. Now, there are some situations where even if you're experiencing your first flare, you really should be considering starting urate lowering therapy. So that's in a patient with chronic kidney disease stage 3 or above. If the patient has a really high serum uric acid level, despite it being their first flare, so it's like 9 or above, or if a patient is having a lot of urolithiasis. These are all situations in which a first flare of gout would actually warrant some urate lowering therapy. Now, sometimes though, we check a uric acid level because it's part of the monitoring labs, or even just a family history of gout and you just want to see where you're at. In those cases, if you have not yet had a gout flare and your uric acid level is above 6.8, we do not recommend initiating urate lowering therapy because you technically haven't had your first gout flare yet. Now, in patients with that you are going to start urate lowering therapy, allopurinol is the preferred medication to use in these cases. Xanthine oxidase inhibitors above probenecid and pegloticase, but even allopurinol above febuxostat. And we'll go into why that is in a second here. And we also achieve something that we call, and I think this is on the next slide, but we treat to target. It's a treat to target strategy. So we basically try to get that number below 6 milligrams per deciliter. In tophaceous gout, we try to go even lower. We try to go below 5 milligrams per deciliter. There's a strong recommendation to start an anti-inflammatory prophylaxis therapy with the idea that we're going to prevent the anticipated flare that will occur if you start something like allopurinol. So that means starting colchicine, NSAIDs, or prednisone. And that's going to be based off of the comorbids. And actually keeping those medications on board, like I mentioned before, for 3 to 6 months rather than just keeping it on for a week or two. With the idea being is that those flares can occur anytime within that first 3 to 6 month period, especially if you're still working on titrating up those medication doses. Now, when it comes to when to start urate lowering therapy, you might recall that there was that old saying that never start allopurinol in the middle of a gout flare. And there is data, like I just mentioned, to show that starting allopurinol can induce gout flares. But what we found is that if you delay things like that, adherence drops significantly because patients just aren't in the moment of being told to take the allopurinol. They might be confused as well. And if you're already treating a gout flare with prednisone or colchicine or something like that, if you add the allopurinol, it's not going to get any worse. And so, as long as you continue to use that prophylactic dose afterwards, we oftentimes find that we are more successful with getting urate lowering therapy on board appropriately if we actually start the allopurinol during the gout flare. So, that's a conditional recommendation. And there is a strong recommendation against using that fancy pegloticase as first-line therapy, mainly because of the costs associated with it, as well as the significant side effects. We talked about the treat to target strategy, where we try to get below 6 for the vast majority of patients, below 5 when there's tophi involved. We are looking into here at WVU Rheumatology of having our clinical pharmacist help with the treat to target strategy, where the patient can actually work with the clinical pharmacist in titrating up those doses of allopurinol without requiring appointments or phone calls every time from the physician or PA or NP. Now, as I mentioned before, there are some patient populations that can have that really dangerous rash that accompanies allopurinol use. And it really comes down to two major demographics, and that's the Southeast Asian population, so the Han Chinese, Korean, and Thai, as well as African American patients. And I'd say that I do quite a good job of checking this allele called the HLA-B5801 on the Southeast Asian patients. And yet I sometimes forget to do it with our African American patients. But the recommendation from the American College of Rheumatology is that both populations should be getting that allele checked to make sure that we're not running into the issue with the life-threatening rash of the allopurinol hypersensitivity syndrome. So we do not recommend to test all patients on allopurinol for this. We do not really need to check your Caucasian patients. Now, for febuxostat, as I mentioned before, there is some data about a cardiovascular risk involved with it. But although more recent trials have actually started to raised some concerns that that might not be very accurate. And even though we had a trial done in 2018 that said that there is no link, it wasn't strong enough for the FDA to retract their black box warning. So febuxostat does have a black box warning for cardiovascular events. So we tend to avoid it in a patient with a significant cardiovascular history. And when it comes to probenecid, you might think that, oh, I should probably check the urine to see whether they're actually urinating out the uric acid, but we actually don't recommend that you do that. It's not reliable enough to see if it's working or not. Here's an example of that life-threatening rash. Again, you might look at that and say, oh, that's not all that bad. But unfortunately, much like Stevens-Johnson syndrome, internal organs can start to fail based off of this inflammatory response. And so that's why we check the HLA-B5801 on these patients. But this can also happen in Caucasian patients with chronic kidney disease. And so that's why when it comes to starting allopurinol in somebody with CKD, depending on their GFR, we're actually a little bit more conservative with our dosing. So we still might get up to somewhere like 4 to 5, 600 milligrams of allopurinol, but depending on the GFR, you might actually only use it every other day. You might actually only use 50 milligrams every other day. And in somebody with significant renal dysfunction, you might only be using it once or twice a week. And this was just a slide that I'll skip over for now for time's sake when it comes to the risk of cardiovascular disease with febuxostat. But again, more recent trials have suggested that that risk is not present, but it still has not changed the FDA's mind to take away the black box warning. I actually tried to convince a cardiologist in Myrtle Beach, hey, there's this fast trial. I think we can use it. You okay with me starting it? And the cardiologist said, did the FDA remove the black box warning? And I said, nope. And then they said that I'm not going to remove my recommendation to avoid it. And I said, fair. Now, when it comes to continued use of these urate lowering therapies, if a patient has failed to achieve their uric acid goal. Uh, but they failed to reach a uric acid goal, or they continue to have frequent flares and non-resolving tophi, you switch therapies. That seems, reasonable to do. However, if you haven't reached below 6 milligrams per deciliter and there's no tophi and they're actually not flaring, but that number is just hanging out at 7 or 8, you actually, if you're maximally titrated on the medication that you're already on, we don't recommend going to pegloticase. But the major reason being is that you're just trying to treat a number at that point, and you might be introducing a lot of risk with the pegloticase itself in terms of the anaphylaxis and the cost. This is just another sort of gout flare management recommendation that you should probably be using the cheap medications like colchicine, NSAIDs, and glucocorticoids instead of busting out an expensive medication like anakinra. And even if the patient has been instructed to take nothing by mouth because it's around surgery, instead of doing the expensive IL-1 inhibitor, we would still be using like an intramuscular or intravenous steroids. Lifestyle modifications, right? Patients are going to come and they're going to say, hey, I don't want to take medications. Can I just do this all by diet? Even in the best anti-gout diet that you could achieve, the most that you're probably going to achieve in terms of dropping the uric acid level is about 1 milligram per deciliter. So if somebody's coming in with a serum uric acid level of 10, the most you're probably going to get out of that is getting down to 9. And so for those very severe gout patients, you're probably going to still want to recommend using urate lowering therapy. There's some talk out there about adding vitamin C, which we feel like hasn't really moved the needle much. I know that some people also talk about tart cherry juice, which actually has some xanthine oxidase inhibitor effects in it, but we don't know how to dose that. We don't know what 2 cups of tart cherry juice is going to be equivalent to when it comes to allopurinol 100 or 300 milligrams. So we still recommend the pills because it lets us fine tune the treatment there. In terms of the anti-gout diet, you really want to avoid those things like the liver, kidneys, sweetbreads, and heart that's just so high in purines. But everything else you can have in moderation. And so for a patient that has gout but enjoys a ribeye steak, yeah, have it. Life is short. Go ahead and use it. Just don't eat a ribeye steak every day. And that's super expensive. So don't do that. When it comes to things like drinking alcohol, you don't have to avoid it completely. Now you're an adult, you're obviously, hopefully, old enough to drink. And so if you enjoy having a beer, you earned it. Have that beer. But if you drink too much of it, then you're just going to drive your uric acid level up. And so a lot of these things are in moderation while still making sure we give the recommendations that you should try to lose weight if you can, stop smoking if you can, because those are modifiable risk factors that could significantly impact your gout disease. And then there are some medications, like I mentioned before, that we are using that could maybe be changed in the setting of a gout patient, like hydrochlorothiazide, we know induces gout flares. So if we can switch to a different blood pressure med, and actually there's some protective effect when it comes to losartan. So maybe that's a better choice for us. ACE inhibitors don't have that same effect. Now, in terms of other types of medications like low-dose aspirin or adding in or switching to fenofibrate, we haven't found that that's been helpful. Those are some things that have been brought up in the past. So before I get into some of the cases that I have established here, I know we only have 17 minutes left. So if anybody has a case that either they were thinking about sharing with the group and they wanted some recommendations, I'd be more than happy to give you the mic here and share your case so I can help you with managing gout. Or if you have an interesting story or anything like that, I'd be obviously open to having you talk about that too. If we don't have any cases, then I have a couple cases that we can discuss. Okay, so this first case number 1, is actually the patient case that was attached to the New England Journal of Medicine review article from 2022, where they sort of opened up the review article with this patient case. So they didn't exactly give the answer, so I figured we could walk through it together and see what maybe would be best for this patient. So a 64-year-old man presents with pain in the left foot. The patient's foot is red and swollen, and he is unable to bear weight on it. He has had similar past episodes involving the big toe of the right foot and the right elbow that were alleviated with naproxen. Unfortunately, he has several comorbids, including hypertension, type 2 diabetes, moderate chronic kidney disease. Physical examination reveals warmth and redness in the left first MTP joint, which is exquisitely tender, and he has nodules over both elbows. How should the patient be evaluated and treated? So, based off of what we discussed, from a diagnostic standpoint or from an evaluation standpoint, is there something that if we had every resource available at us in training that we could do, something that we could do to just at least establish the diagnosis with a high degree of confidence? I think I saw somebody mouth it over there. I think you're muted right now, but aspirate,
Tap the
right?
joint.
Tap the joint, exactly. So there's the old saying, aspirate or litigate, right? So I remember when I was studying for my internal medicine boards, I went to a review. I went to a review session, and the doctor who was giving the lecture pretended that he was, the person that was litigating in this setting. And they said, "Well, doctor, why did you just assume that this was a gout flare? Well, it turns out that it was a MRSA infection in the knee. And by you delaying treatment by using colchicine and prednisone, you actually lost precious time that septic arthritis could have been treated." And so, although that's a little bit CYA, the idea behind it stands, right? In that you lose precious days, hours, days, weeks, months chasing down a gout flare when in reality, maybe it's not something as scary as septic arthritis, but maybe it was rheumatoid arthritis or something along those lines. And so, right, it still comes down to the gold standard of tap the joint, prove the synovial fluid has monosodium urate crystals. If they are in there, you are good. You have proven that they have gout, and go ahead and treat it as a gout flare. But you might also be surprised, right? Sure, there might be a little bit of a high uric acid level, but these gout crystals are quite easy to identify in a synovial fluid aspirate, whereas the pseudo gout crystals, not so much. So if you actually have a synovial fluid aspiration and you see no gout crystals, but you actually see a few pseudo gout crystals, even though the uric acid level is like 7 or 8 or something like that, this could just be pseudogout. Now, that's an unfortunate situation if that's the case, because with allopurinol, you have all these treatments that I just discussed here with like allopurinol and febuxostat, even going as so far as pegloticase. Whereas for pseudogout, we use a lot of things off label. We might try using methotrexate to help out, but oftentimes we're just being very reactive with our management, where we're giving steroids and NSAIDs and colchicine. And sometimes we just keep people on prophylactic therapy. So, from an evaluation standpoint, absolutely, we should be tapping that joint. In terms of treating this patient, and so taking a look at some of their comorbids, they have a history of hypertension, type 2 diabetes, and moderate chronic kidney disease. And so you almost have a reason for each of the acute management treatments to not use it, right? So if we think about NSAIDs, this patient has chronic kidney disease and hypertension. Probably not the best situation. How about steroids? Type 2 diabetes. So it might come into play about like, well, how bad is their diabetes, right? Are we just talking about pretty mild, or are we talking about this patient in the past had some severe complications like diabetic foot ulcers, DKA? So yeah, maybe you don't want to be messing with steroids. Colchicine, a little bit, on the fence here with that chronic kidney disease, but as long as it's not severe chronic kidney disease, I think colchicine might be the way that you could go for treating the acute flare. Now, notice though that this patient has nodules over both elbows, so the presence of tophi. And so, even if this was his first flare, which it wasn't, but even if it was his first flare, you would obviously be pursuing urate lowering therapy with allopurinol, and based off of the GFR, maybe modifying the starting dose there and increasing it as tolerated. So, case number one, a case of moderate, almost severe gout, has nodules, so it's getting there. We definitely want to be using urate lowering therapy. Question. Yes, Dr. Rexford.
Well, actually, I
Sorry,
just
you're
pulled
saying.
up the chart of a patient who he's a
Yes.
65-year-old man who has had gout. He has also had CPPD.
Yeah, yeah. They can
So, when
coexist.
he
They can
comes in with a
coexist.
hot swollen joint, we got to figure it out. Um,
Yeah, yeah.
and actually, he was here in June with a swollen shoulder and a lot of pain, and he didn't have either kind of crystal.
Oh God. Did he
He's
happen
on
to have
allopurinol
Milwaukee
300.
shoulder or
He's on
okay,
300
Al
allopurinol. His
okay.
acid level the last time was 3.4. So
Okay.
I
Yeah.
think
Now
we're
was and that's an important point that I didn't address earlier, so thank you for bringing it up. Was that uric acid level obtained in the setting of the gout flare?
no. That
Okay,
was
good.
on. We were following it.
Good. Because actually, the recommendation as well, and I'm sorry I didn't touch on it earlier, is that you actually try to get that uric acid level several weeks, even up to 4 weeks after the gout flare. Because much like a high schooler that found out they have a group project due the next day and they're rushing to do everything at the last second, your body in the middle of a gout flare will, in some patients, not all of them, and I think it's only like 10% of patients, but in some patients, the body will say, gout flare. Uh, get rid of the uric acid. And so it starts dumping uric acid in order to try to compensate. The ER doc grabs the uric acid and says, it can't be gout. Your uric acid's 5. You're fine. You should, it's something else. When in reality, it's gout. And so you did it correctly, but just keep that in mind where if you swore this was going to be a gout flare, maybe there's the podagra or that first MTP pain and swelling. Maybe try to recheck that uric acid a little bit later, but go ahead and get it during the flare as well. In that setting, you said they're allopurinol 300. They've met goal, right? So they're below 6. I'm assuming there's no tophi. But even if there was tophi, they're less than 5. And they're still having flares, right? How frequent are the flares?
Once a year, maybe.
Okay.
um,
So from that standpoint, as you'll see in the next case, I say this um, with empathy. I say this with empathy. I'm not trying to discount these symptoms. Um, One flare a year, you could probably get away with just treating it with that colchicine or whatever you choose, like prednisone, NSAIDs, and say, well, even if it was CPPD, let's just treat that flare at that time. Now, if it's more frequent though, and you're confident that you've met your uric acid goal and you've proven pseudogout crystals, you may want to involve rheumatology there for uncontrolled CPPD because we could potentially start some other off-label medications, whether it be a methotrexate or something like that, to see if that will help. No, no guarantee that it would. Or in some cases, you just keep them on the prophylactic dose, which even some of these medications like colchicine has some long-term risk. Um, and of course, if you just keep somebody on 5 milligrams of prednisone, that will induce some problems too. That's why I get so frustrated with those pseudo gout cases because we haven't found a medication or even a lifestyle modification, to be quite honest, where we can confidently say, okay, you're going to be good, right? And so oftentimes we're reaching for colchicine, prednisone, NSAIDs, and maybe methotrexate. So uh, tough, especially if you have both, right? Both types of crystalline arthropathies, or two types at least. There's another one. Now, case number 2. I know I said, what's he talking about this empathy thing? So, a 37-year-old male with no significant past medical history who has had 2 significant gout flares over the past 4 years, presenting today without a gout flare. I should put that in there. No gout flare today, but he's been avoiding seeing a PCP in recent years. But they say, oh, you've had gout flares before? Yeah. So let's just check your uric acid level, and the uric acid level is 8.8. How should the patient be evaluated and treated? So we already said it, right, Dr. Rexford? We tap the joint if you can during the middle of a flare, try to prove that it's gout. But as I mentioned before, you can actually tap the joint in those intercritical periods and prove it that way as well. But let's say you got this know-it-all patient. They're like, no, 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 I don't want you to tap it. I know it's gout. I know it's gout. No, no tapping. And then how can you be so sure? And you say, because I'm a rheumatologist. This is my specialty. I know I have gout. And the thing is, that is my foot. That foot on the right there is my most recent gout flare from 2024, and it was probably my worst one yet. I had just moved back to Morgantown, and we went to Red Lobster, and I got the Seaside Shrimp Trio. I've been eating that since I was a kid. And my wife looks at me, and she was just like, "Don't you dare complain once that foot of yours just explodes." I was like, what are you talking about? It's fine. I had shrimp down in Myrtle Beach. It's fine. Nope, this was my worst one. And at the time, I had a 3-year-old, and it's almost like he was a homing beacon. I was so quiet, just slumping around. I didn't want to do anything. I came into work and all my colleagues are like, "What's wrong with you?" And I'm like, "I have a gout flare." And my son stomped on my foot accidentally, and that was probably the most pain I've ever experienced in my life. Um, and yet, I am not on allopurinol. I've had two flares, but they've been spread out over the course of several years. I just hit that mark that if I'm going to use the ACR management criteria to a T, that I'm not technically over 9 milligrams per deciliter. So I can reassure myself that way. I've tried to make some lifestyle modifications. I'm increasing my exercise by playing adult kickball in an adult kickball league. So I'm being more active. I've cut out pop from my diet completely, whereas before I lived off of Cherry Coke and Mountain Dew Livewire. And overall, I think that I've avoided shrimp, which is very sad, but I do it. And so, from that standpoint, thankfully, Dr. Zabelek, I haven't had to call off work or anything like that over the last year, and it's because I haven't had a gout flare in that time. I'm a little scared to see what my uric acid level is because I don't want to see if it's crossed into above 9, and all of my avoiding pop has been for naught. But technically, again, urate lowering therapy, less than one, or fewer than one flares in a year. No, and no advanced things like, let's say, radiographic changes or a tophus development. I don't have any of those, and so I've avoided using allopurinol. Now, you would say, okay, so you got it tapped, right? Because if you're going to talk the talk, you better walk the walk. And, once it's something's changed sometimes, right? You're like, don't put a needle into my foot. I don't want that right now. And so thankfully, one of my colleagues, Dr. Kasim, is ultrasound certified. She put an ultrasound probe on my foot. She saw the double contour sign. So that was, again, very indicative of gout. Now, our last case here, because we got just a couple minutes left. This is a 72-year-old male with a long history of crystal proven gout. So, did it the right way. Worsening disease over the last 3 years. Tophi are extensive despite maximally titrated allopurinol. So, 800 or so milligrams of allopurinol. Maybe there's a cardiac history, and you can't use febuxostat, CKD, so you're not using probenecid. Tophi have started to break open and become infected, leading to hospitalizations and surgeries. You've got incision and drainage surgeries, sometimes even amputations, trying to get rid of all these tophi. Now, I will say, especially for those in the room that get a little squeamish, or if you're not so much on the medical side of things, I am about to put a picture up of a patient that I had in March 2020. This is a week before the country shut down. I remember this because it was also a week before I got married. And it's probably the worst case of gout I've ever seen. Young guy, um, you know, not for this specific case or this patient's case, but we had put him on pegloticase, or Cristexa is the other name. And it was quite effective, but this was before we knew we were supposed to be using a lot of methotrexate to help prevent some of these complications. And he got anaphylaxis on the pegloticase, so we stopped using it. And unfortunately, he ended up passing away from the complications of all these infections with all of his gout. So gout can get quite severe. So the trigger warning here is that I am going to show you his ankle, and it will show you how bad gout can get. So again, if you get squeamish, you might want to just look away for a second. So this is his tophaceous gout. If you take a look at the heel, you'll see a more typical tophus, that firm nodule, that chalky appearance. But sometimes it gets so bad that it just liquefies. And so that's what kept on happening to this patient. And even if you take a look actually on the other heel at the top of that picture, you even see the tophi up there too. And so this gentleman he was suffering, and we tried to use everything we could. This was a personal patient of our section chief up at Penn State, and it unfortunately led to the worst of outcomes. And so gout is, I joke, in case two about, like, I don't want to take allopurinol, things like that, but it reaches a point though where you have to treat this as seriously as any other, rheumatologic disease or any other medical disease, because it can be as bad as, diabetes and things like that. So the sad part is when these things happen, when a patient just has never been on urate lowering therapy, and this could have all been prevented. So hopefully today's presentation gave a little bit more reassurance that there's a lot of things that we can be doing in the non-rheumatology setting. being a little bit more aggressive with our urate lowering therapy in the right context, and also knowing that there are options out there that we in rheumatology can pursue, especially pegloticase, which we do not expect you to do on the outpatient setting in a non-rheumatology setting, but to prevent these things from happening, because a lot of these things are preventable. And there's more and more research coming out that even in this asymptomatic hyperuricemia, that patients might benefit from allopurinol, mainly to decrease cardiovascular risk. So with that being said, I think that's my time. So if there's any final questions, I'd be happy to answer them. There's references, but here's my contact information. I am always open to helping out a fellow gout patient out there. So if you ever run into a situation and you're like, hey, I got this guy with gout, I'm like, all right, I'm all ears. Hit me with it, and I'll try to help them. And if for whatever reason we can't do it from just a discussing the case standpoint, we're always open here up in Morgantown to help out. But always hoping to help.